gonna moderate for myself again. Um, I'm Jerilyn Arneson, and I'm a board member of NAMAPA, and I'm also an oncology pharmacist and a revenue integrity pharmacist, and been in healthcare for a little over 22 years, and got into Medicare through the infusion center space. And when I was setting up patient assistance programs, and honestly, I just was like frustrated because I could not figure out the difference between a Medicare Advantage plan and a supplement, and I had just had it. So, so I saw there's an opportunity to volunteer at Senior Services of Southeastern Virginia, and for 4 hours a week, in exchange for 4 hours of volunteer time, I took 22 Medicare modules. So if you want to talk about boring Medicare, 22 Medicare modules I did, um, just so I could better help my patients, because I just knew that you know, I have my own. It's probably not just me, but I think there's some of us who feel like the future of patient assistance is kind of, I don't know, it's kind of up in the air. We have to have some sort of backup plan, you know. And one of those ways of making sure that patients are still taken care of is to optimize their insurance. And the big one would be Medicare. So I'm going to cram those 22 modules into an hour, to 58 minutes. So, anybody, well, I just got this bad. Like, anybody else feel like this is unusually large? It's very distracting. Okay, so I definitely have no conflicts of interest with Medicare, that's for sure. Okay, so just in case anybody else is nerdy, wants to pursue doing this, there is something called a certified Medicare benefits counselor. Every state has a SHIP, which is the State Health Insurance Assistance Program. So you can volunteer at the SHIP office, and it's usually like an office on aging, or like, senior services or whatever. And so everywhere where there's SHIP, we do free Medicare training, and it's mostly for new to Medicare patients. But we also would do, during open enrollment time, which is coming up October 15th to December 7th, we would also review people's plans and look for opportunities to change them to a different plan that might save them money. But anyway, we didn't get it's free service. We didn't receive a commission. In contrast to probably right now, brokers are probably blowing your patients' phones up. It's getting ready to be open enrollment. And unfortunately, they get, because they don't know any better, and the whole topic is so confusing. They go for, zero premium. They just hear zero premiums, or how little they have to pay or whatever. So they get suckered into being on bad plans that end up costing them a lot of money in the long run. So if you're interested in doing this, I have the SHIP website up there, and phone number. And I will say, like, just working with the senior patients, it was kind of fun, honestly. And I learned a lot. A lot of situations that I didn't ever think about, and also, and we're going to talk about this in a minute, just like how many of our seniors are really poor. And so if you're the working poor, you're going to end up being the elderly poor. And we have a lot of elderly poor out there, which is unfortunate. So one thing that, and I should back up a little bit. So I spent 14 years in military medicine, and then in 2014 I transitioned over into civilian medicine. I didn't have any understanding of Medicare. Like, I mean, I knew it existed. I didn't know how it worked or anything, and I would routinely like switch, interchange Medicare and Medicaid all the time, and didn't know how it worked with Social Security. So I just put this comparison chart here to show, Social Security and Medicare and Medicaid, they're all intertwined, but Social Security is income, Medicare is healthcare, and then Medicaid is healthcare for low income. Um, Social Security and Medicare are both federal programs. Medicaid's a state program. And so, a little bit about Social Security is that I'm not sure, I did not know this, but full retirement age is 66 years, and I believe it's still 4 months. It might be 8 months, but it's soon to be 67 years old. And so Medicare starts at 65, and um, you can start collecting at 62, but it reduces your benefit amount. And that reduction in the benefit amount stays like that for the rest of your life that you're collecting benefits. So, like, it's like once you hit full retirement age, it doesn't bounce up to what you should have gotten if you were to retire at full retirement age. You're stuck at that 62, that's 75% of the benefits for the rest of your life. So I was surprised to see this. How many people actually wait until full retirement age? So the majority of people actually start collecting at 62. That's a pretty big chunk of the population. Only 18% actually wait until full retirement age. Um, so how do they calculate how much you're going to get from Social Security? It's based on the average of your highest paid 35 years of work history. Um, but I was also surprised to find out that the average monthly Social Security check is only $1,670. Um, and that actually, it is in line with what I was seeing in the community, unfortunately. When I would go to collect applications for patient assistance, a lot of the patients weren't even filing taxes because they didn't make enough money from their Social Security. But for a quarter of our seniors, it provides 90% of their income. And pensions just aren't around anymore. People just don't get pensions the way they used to working at, Ford Motor Factory. And so you're supposed to be paying into your 401k, but at the end of the day, most people can't afford to contribute to their retirement account. So the two main reasons that they collect the benefits before the full retirement age is financial need, obviously, and then poor health. I think I jumped a slide. Okay. So then what do you do? Ugh, darn it. What do you do if you start collecting at 62, but Medicare doesn't start till 65? So Medicaid is an option for some of our seniors, but there's still 12 states out there that haven't expanded Medicaid, and their federal poverty limit is really, like, I don't know who could make these poverty limits that are set by some, like, especially Texas is really bad. But most states it's 100% of the federal poverty limit. I know in Virginia it was 80%. Um, but yeah, it's harder when you're a senior. Um, and then your previous employer. So some employers do offer retiree benefits. And one thing, that I counsel those patients who are in retirement plans is if they like it to stay in it as long as they can, because once they leave, they can't get back in it. So, if they have like Blue Cross Blue Shield Federal, like if they ever leave that, they can't go back to it. So, um, they can get Cobra, but that only lasts for 18 months max. What I see quite a few people doing is going to the marketplace, and then if they are still married, they can get coverage through their spouse's employer. But let's just go on to Medicare. I think most people know the different parts. A, B, C is not really a part, it's Medicare Advantage, and Part D. We'll go into these a little bit in more detail. This is kind of hard to see, but you basically have two pathways. So when a patient is new to Medicare, we put this in front of them and show them, okay, there's two options for you to get Medicare. You have to get A and B before you do anything else. But once you get A and B, you can choose to either go Medicare Advantage, which is your A, B, and plus or minus Part D wrapped up into one, um, or you go A and B, you get a supplement, but you also have to get a standalone Part D program too. So, so enrollment, I get a lot of questions about enrollment. Um, do I need to enroll myself? Is Medicare going to send me something? A lot of people miss their enrollment opportunity because they are waiting for Medicare to send them something because they think that they're automatically enrolled when they turn 65. But you're only automatically enrolled if you have started collecting Social Security benefits. So, um, so if you were collecting them early, then it does automatically enroll you. Also, the other time you have automatic enrollment is if you were awarded disability and you've been on disability for 24 months, on that 25th month, then Medicare starts. For non-automatic enrollment, you've got a 7-month window. So you've got 3 months before your birth month, yeah, before your birth month, and you've got your birth month, and then you've got 3 months after your birth month. So you've got a 7-month window. We prefer, obviously, for people to start the process in that 3 months prior, because if you're not automatically enrolled, you've got to sign up through the Social Security Administration. They have to send you the red, white, and blue card. Then you've got to then decide what are you going to do as far as Medicare Advantage or a supplement, and all of that takes time. And if you want that to all start on the first day of your birth month, all of that stuff has to happen during those first 3 months. So where I try to catch patients, if they're enrolled in a patient assistance program, um, or I'm, following them for some other reason, and I know their 65th birthday is coming up, I'll tag them to start having the conversation about Medicare, um, and get them started on that process. So it's kind of like I took my volunteer work, but then I started incorporating it into my work with patient assistance at the hospital. And we won't go over all of these, but there are other enrollment periods for Medicare. The one thing that is going to change in 2023, it used to be those 3 months after your birth month. If you enrolled in Medicare those 3 months, you weren't subject to a penalty or anything, but your wait time increased before Medicare Part B would kick in. So, like if you enrolled in that seventh month, you could wait up to 3 more months before Medicare would actually start. But that's going to change in 2023 so that whatever month you enroll in that last 3 months, Medicare will start the first of the next month. So that's a positive change. So I would say the first way you can save patients money is to make sure they sign up during their 7 month enrollment window. Because if they don't and they miss that, they have to pay Part B penalties, Part D penalties, and it's per month. And those penalties you have to pay for the rest of your life while you're on Medicare. So, you know, there, we won't go into this, but there are patients who work up until full retirement age, which is, 66 and 4 months or 8 months or whatever. When that happens, you actually have to decline Part B if you want to stay on your employer plan. And so some patients will forget to reinstate Part B, and then they've got a coverage gap. And during that coverage gap, they're accumulating penalties, and they've got to pay those penalties for the rest of their life. So it can get, again, it's like I keep saying, like, I don't know how they would expect. They send out this booklet called Medicare and You. It's, I don't know, 70 pages long, and expect that the patients are going to read it and be able to understand all of this from this Medicare and You handbook. Okay, so the most important part is signing up for Medicare's Part A and B, and there's 3 ways to do that. One, like I said, is online through the Social Security website. I will give the Social Security Administration credit because their website is very easy to use. It's very easy for patients to go on there and enroll. It's also we'll talk about this later, but it's also easy to enroll patients into low income subsidy and extra help through the Social Security website. If they really want to torture themselves, they can call the Social Security hotline. I do not advise it, but and then even worse, if they just want to be abused, they can go in person to their local Social Security office. So, okay, so after they sign up for parts A and B, they're going to get this red, white, and blue card, which it's a little different now. It used to have their Social Security number on it. Now it doesn't. It's got this Medicare number on it. If you want to help a patient out and go to the Medicare.gov website and help them enroll in either an Advantage plan or just help them create an account where they can then go in and compare plans and stuff, they need that Medicare number and the Part B start date. So it's you can do the plan. You can go to the plan finder, put in the zip code, and do all of that without their Medicare number. But it's better if you can create an account, because then you can type in their drugs and it saves their drugs into the plan finder, and you can come back to it later and all of that. So this to me is the easiest, and um, again, the zip code, and then you can look for a Medicare Advantage plan. You can look for just a standalone Part D plan if it's open enrollment and you maybe want to change. Um, if that patient wants to go down that path where they're going to get a supplement and a Part D program, you can look at both of those, Medigap only. And there's just a wealth of information on the Medicare.gov website, honestly. So it's a little busy. I realize, but Part A is your hospital coverage. Um, if you've worked 10 years and paid into Medicare taxes, it's premium free. Part A is. But the deductible, if you have a hospital stay for a Medicare patient, is $1,500. And that's per benefit period. And the thing to know about benefit periods is that there's a new benefit period if the patient gets discharged, stays out of the hospital or a SNF for 60 days, and then gets readmitted. They've got to pay that 1556 all over again. There's no limit on the number of benefit periods, so they could potentially pay 6 benefit periods, pay 6 deductibles. But it covers your inpatient hospital stays, your SNFs, your some home health care. I want to say some home health care and hospice. Then Part B, everybody pays 170, 10. This next year, they're thinking it's going to go down. It jumped up by double digits last year because they were anticipating the cost of this Alzheimer drug um, sucking up a lot of the money. So the premium may actually go down. If you're a higher earner, and there's a chart on Medicare.gov, but if you're a higher earner, there's something called IRMA. They'll have to pay extra Part B premiums depending on their income. The deductible is only $233. However, if you just stop at Medicare A and B and you don't get an Advantage plan and you don't get a supplement, that 20% coinsurance is forever and ever and ever. It's unlimited. There's no cap on it. And so you see what I would see a lot is those patients who retired early at 62, got automatically enrolled into Medicare's Part A and B, and didn't know that they needed to do anything else and just thought that was enough. And then those are the patients that unfortunately will show up in the infusion center not knowing that there's no out-of-pocket limit, and they get themselves into trouble really fast and have high balances. But Part B covers your doctor's visits, your outpatient care, x-ray and labs. Preventative care is also in there. Part C is your Medicare Advantage plan. So many seniors get sucked into these Medicare Advantage plans because 70% of them don't have a premium. And I'm sorry if you hear my same joke again, but all I think about is the Humana tents in the Walmart parking lots that are like recruiting seniors as they go into Walmart, signing them up for these crappy Medicare Advantage plans. And then they have really high out-of-pocket maxes. Like, I mean, the maximum out-of-pocket max is $75.50. Just remember that out-of-pocket max for Medicare Advantage is different than your out-of-pocket max for Part D. So you've got two high balances that you could be making. I always love that they're like, well, you get additional benefits like vision and dental and hearing. Yeah, well, it's really crappy coverage. It's really bad. And they're better off just getting a separate dental or a separate policy because they're so big, they cover so little. And then if you're going to help someone get into a Medicare Advantage plan, the number one thing you have to think about is to make sure that their physicians or providers are in the network. That's the draw. They're HMOs and PPOs. So you've got, a network of physician and hospitals, and, your elderly patients get quite attached to their doctors, and then they get enrolled into a Medicare Advantage plan and find out that doctor's not in the network, and they get very upset about it. So, And if that ever does happen, no, there's a special enrollment period, January 1st to March 31st, where if you're in a Medicare Advantage plan that you don't like, you can switch to a different Medicare Advantage plan. So that's a okay. And then last is Part D, which is the prescription drugs. You can have a standalone plan or have it included in your Medicare Advantage. It says the average premium for 2022 is $43, but honestly, when I help patients, the last patient I got into a Part D plan, the premium was like $6 or $7. I mean, there's really, and we'll see this when we look at supplements, that you just have to really shop. I mean, there are some low premium plans where patients can get what they need. But it's a $480 deductible, and we'll go into the benefit design structure a little bit more. Um, they pay 25% up until they get to that catastrophic phase, which then they either pay 5% or they pay, I think it's like $395 for generics and $980 for brand name. So whatever is less expensive. And then just um, to keep in mind with Part D, each plan has to have 2 drugs per class on their formulary. So it may not, you know, may not be the one that the patient is on, but um, it's this is Part D is where I feel like pharmacists can really intervene and help out a lot by trying to get them on a Part D plan or switch their drugs that's included in their Part D plan. And then Part B, this is where your infusions and injections live. Um, Part B covers infusions and injections regardless of the site of care. So if it's a hospital outpatient infusion center, if it's a physician infusion center, if it's a standalone, if it's home infusion, that's all covered by Part B. And then as far as Part D with the prescriptions, they have different tiers. Um, and so they're going to pay a different copay, and I don't know what they're going to be for 2023 yet, but they're going to pay. Some Part D plans actually have $0 copays for their generics, but um, the specialty tier is, where they get themselves into trouble and they have to pay anywhere between 25 and 33% co-insurance for the specialty meds, which just, my mom happens to have CLL and is going to be put on ibrutinib, and ibrutinib, I think the cost is around 19,000 for a 30-day supply. So 25 to 33% of that is a pretty good chunk. It ends up being, I don't know, like $3,300 or something like that. So um, most seniors can't afford that. So this is what the benefit design looks like. So everybody has to pay the 100% of the 480. Then there's the initial coverage phase. But notice the patient pays 25%, but their portion is only $1,100. So they don't have to pay all the way up to that 4,430. That's a combination of what the patient pays plus what the plan pays. Then once they step out of that, then they're going to enter into the coverage gap, which was the donut hole. They don't like you to call it the donut hole anymore. It's the coverage gap. So they still are going to pay 25% until they reach 70/50. But again, that's not all of their responsibility, that 70/50. This time, from the 4430 to the 70/50, it's the patient's 25% plus the manufacturers for brand name, they pay the other 75%. So if the patient is paying 25% for the generic, they could be stuck in that coverage gap all year. So then once they get out of the coverage gap and are into the catastrophic cap, then it's going to be 5%. And then you can see the different copays based on price. So probably everybody has heard about the new Medicare rules, and there's been lots of like cheering about it, but I was like, all right, calm it down, because number one, the Part D cap isn't going to take effect until 2025. Yeah, 2025. So it's still 3 more years that we have to deal with um, high out-of-pocket costs. Next year, I guess the big thing would be that before, only some Part D plans had insulin for $35, but now every plan has to offer it for $35. And then 2024, I think that's probably pretty big too, because it eliminates that 5% coinsurance in the catastrophic cap, because still people think, oh, 5%. I think I said it wrong before. I said 5% or the copay, whatever's less, but it's 5% or the copay is whatever's more. But 5% of 20,000 is still, what is that, 1,000? It's still a lot of money, to pay and the catastrophic cap, there's no cap to it. There's no ceiling on it. So I think 2024 would be a big year. Then as far as negotiated prices for the high cost drugs, again, I'm like, calm it down. It's not going to be all 60 at once. They're just going to do the top 10, and that's not happening until 2026. So they're going to phase this in, um, and we will see. It'll be interesting to see how it affects patient assistance programs once it caps it to 2,000. You know. Okay, so Medicare supplements. Um, so there's you've got six. Okay, so when you first enroll into Medigap, if you're within that 6 month period, you have to be 65 and have Part B to enroll in a supplement. The supplement and Medigap are the same thing, and I didn't know that for the longest time. So, you have to be 65 and have Part B in order to enroll in a Medigap plan, where you're not subject to medical underwriting, meaning they can't exclude you for pre-existing conditions, or they can't raise your premiums for pre-existing conditions. There's a little known clause that a lot of people don't know about, where if you are new to Medicare and you enroll in a Medicare Advantage plan and they're unhappy with it, because Medicare Advantage plans, like the way I look at them, they nitpick you to death, with these pay-as-you-go types of things. It's like $250 for this and $50 for this. So and then they don't realize, like, oh, the out-of-pocket max is $6,000, So if they're unhappy with their Medicare Advantage plan, they've got 12 months where they can switch over to a Medigap plan without being subject to medical underwriting. Now, outside of that, they can, if they want to, they can enroll in a Medigap any other time. They're just going to be subject to medical underwriting, which is then going to increase their monthly premiums. So, but you cannot use it with a Medicare Advantage plan. It only covers whatever Medicare Part A and B covers. So Medicare Part A and B picks up 80%. Well, I should say Part B picks up 80%, and then the supplement picks up that extra 20%, or um, we'll see the list of the different Medigap plans and what they cover. Um, but each lettered plan, so there's A through N, they have to offer the exact same things. Can't can't vary. And there's probably like 40 Medigap plans for one area of the same letter plan. So um, again, this is where patients really get suckered into. But here's what the different um, plans cover. Plan F is no longer available unless you turn 65 prior to 2020. Um, there are like some high deductible plan Gs, um, where it lowers your premium, but you've got to reach a like a $2,400 out of pocket max before it starts picking up that 100%. Um, but we call Plan G the Cadillac plan because they're pretty much set up, and I'm as a Medicare benefits counselor, I'm supposed to be unbiased, but I will tell you I'm not. I am not unbiased. I'm very biased. um, because we completely insure our vehicles, we buy insurance for our houses, renters insurance. Why would we not insure ourselves? Because you never know what's going to happen. Like, I, out of the blue, tore my quadricep tendon right off my kneecap. Not once, but twice. I didn't even know that that was possible. And so I had to have a surgery for it recently. But, that sucked up a big deal of my out of pocket max. So you just never know what's going to happen. They may come in relatively healthy, but to me, that mm, it doesn't make me want them to purchase a Medigap plan any less. So, so I kind of given them that spiel about car insurance and just being prepared. And people live for a long time. People are living to their 80s or 90s, and you only have that 6 months or 12 months window where you can enroll without being subjected to medical underwriting. So it's a small window of opportunity. So I know this is a little old. This is from the state of Virginia, but it's just to show you the how if you just go down the G and the G plus on the right hand side, how much those prices differ. Now, the thing is, they don't offer anything different between any of them. The ones that are more expensive don't offer any additional services. So, again, like the last patient I worked with, she was like, well, somebody from Boomer's Benefits called me, and wanted me to enroll in Manhattan Life. And I was like, all right, well, let's just look and see, because it also, the premium also changes based on, do you want to lock yourself into a premium that will never change the rest of your life, or do you want a premium that's going to increase as your age increases? Because that differs a little bit. But the last two patients that I worked with, um, we just really shopped around, and I got them both on a Medicare G plan, a G supplement. One was for $94 a month, and the other was $92 a month. A lot of that is going to depend on what state you live in. You know, like New York is out of control, I think, and there's some other states that are out of control. Um, Men are going to pay a little bit higher if you're a smoker. I think you are subject to medical underwriting. If you're a smoker, the premium is going to be higher. But that's really the only question they ever ask. Um, Otherwise, to me, it doesn't matter. Like people are like, "Oh, I should go with AARP because I know AARP," or I should go with Colonial Penn or whoever I saw Joe Namath with on late night TV. I'm gonna go with that plan. But honestly, I don't care what the name of the plan is or if I've never heard of it. Like they have to, by law, they have to offer the same things. So, and then if I can lock them in at that premium where it's not going to increase the rest of their life, they're golden. So, I made this as just to compare, kind of give you like what's going through the patient's mind or what they're thinking about. Again, they're seeing that $0 premium with most of the Medicare Advantage plans. Um, the 30% of the plans that do have a premium, as the premium goes up, their out-of-pocket costs go down. So they're going to pay one way or another. Um, but again, it's pay as you go for a lot of the services. They've got the network you have to stay in. The referral and prior authorization process is a pain. Um, and for infusions, they do require, it differs by Medicare Advantage plan, but the requirement for prior authorizations is still pretty high for Advantage plans. Um, that caveat, they include dental, vision, and hearing. But if you add it to what the max out of pocket is, so the total cost of their Part B, so even though it says zero, that's where I hate Humana and the other people that scam them because they're like, it's $0 premium. No, it's not. They still have to pay the Part B premium, and they don't know that. And then all of a sudden, when they get their Social Security check and see it's been reduced by 170 a month, they're like, "Hey, I thought this was premium free," and I have to be the bad one to break the news. Like, no, it's not. So, um, so if you had like a max out of pocket of 75.50 and add that to your Part B premium, you're going to end up paying $9,100, and that doesn't even include your drug costs. So then you compare that to the supplement, and I'm just going to say, 150 for an average, unless you live in New York. Um, if you're male or whatever, and then the Part B premium, and then the average Part D premium they say is 30, so you're looking at $350 a month. Um, but if you add up all those like let's say we get the plan, the G plan, and we add up all those premiums for 12 months, it still comes out to be less than a lot of Medicare Advantage plans. Because a lot of Medicare Advantage plans I've seen out of pocket maxes of 4,000, 5,000. Not all of them have 75.50, but you can get a supplement where in the end it's comes out to be cheaper because you know in Walmart they're not getting counseled that the supplement's going to pick up 100% of that 1556 Part A deductible when they get hospitalized. So there's just so many things that a supplement can, all of the co-insurances that the supplement can pick up, except for the Part D costs. So one of the things I never even knew this existed, um, until I started volunteering was this low income subsidy and extra help. But you know, with you saw the average monthly income for what a social security check is, like, screen all your patients for extra help or low income subsidy. And we'll get into the Medicare savings programs as well. But same thing. I mean, just I was surprised at how many patients qualified. Um, and so if they do get extra help, then they don't pay a deductible or it's reduced, um, and their prescription drugs are reduced significantly. This is just for the 48 states, doesn't include Alaska and Hawaii. I think it's ridiculous that they bicker over the $1,500 burial expense as being whether it's an asset or not. So it's dependent on state. Um, they will automatically get extra help if they do get enrolled in Medicaid, or if they get enrolled in a Medicare savings program, or they get supplemental Social Security income. They'll automatically get extra help. My experience has been it does include the SPs. Yeah, yeah. But I will double check on that. Yeah. Okay. Okay. And then the same thing with Medicare savings programs. I would screen your patients for this, um, because if they qualify for any of these, they get that Part B premium back. They get that 170 per month added back to their Social Security check, and it makes a significant difference for a lot of seniors. So, like, I literally had a patient. Um, she was 68, had Crohn's disease. She couldn't work, you know, um, like constantly throughout her life because of her flare ups and stuff. And so her monthly Social Security check was, or yearly Social Security income was $9,800. And I was like, how is this lady living off $9,800? Well, she and I got to be kind of close, and I kind of flat out asked her, and it was like, well, credit cards, family members, they kind of get it any way they can. So I was able to get her enrolled in Medicaid, and then through Medicaid she got extra help, and then she got her Part B premium back, and she was eligible for all these other programs. But I think it took her income up to like 12,000 or whatever, which doesn't seem like it's a big deal for us, but it's a huge deal for them. So the intent of the Medicare savings program and the way low income subsidy and this works is whenever you enroll someone through low income subsidy through the Social Security Administration, it's supposed to automatically kick off a screening for the Medicare savings programs. But in many states that doesn't happen. Some states it does happen, but many states it doesn't happen, and there's a separate application that you have to fill out for the Medicare savings program. Sometimes you can do it online depending on the state, or you download the form and send it in. But the state pays for the Medicare savings programs, versus federal for LIS. Okay, so I've only got 5 minutes. All right, medication assistance. Believe it or not, there's some patients that just have Part A and don't have any additional coverage. Um, so I treat them as uninsured and try to get free drug for them, and then try to get them into Part B. Patients with Medicare A and B only, um, they've got the 20% coinsurance. You can go the foundation route if that fund has enough money to pick up, depends on what the how much they owe. But usually I do free drug until I can wait until open enrollment and get them into a Medicare Advantage. So that's when I do use the Medicare Advantage plans, is if they're A and B only and I want to cap their out-of-pocket expenses and we're outside that Medigap window of availability, I will stick them into a Medicare Advantage plan. If they do have a Medicare Advantage plan, it's always better to use a foundation if you can, because so let's say their out-of-pocket max is 6,000 and their infusion is, I don't know, $1,000 a month. But every time I can get the foundation, if I get them enrolled in the foundation, it pays that $1,000. It goes towards their out-of-pocket max. So I want to pay off. I want to use that money to pay off their out-of-pocket max, because then the rest of their services are then paid for. Now they can go get the MRI. Now they can go get the surgery they need or whatever. So it's easy to do free drug. It's easy to want to go that route, but it's always better to go foundation if you can. If they have a supplement, there's really no reason for them to need assistance except for if they need it with Part D. And then as far as insurance optimization, this is what I was talking about before, like with Part A, find out why do they only have Part A and get them enrolled in Part B before the penalties start racking up. If they have A and B only, you can enroll them in a Medicare Advantage plan during open enrollment, or you can enroll them into a 5-star plan at any time of the year. Some areas don't have 5-star plans, but there's a lot of areas that do. And so I always check that first, and try to get them into one. Screen all your patients for low income subsidy and the Medicare savings program, and then encourage the supplements if the patient can afford it. And, I think I finished just on time. And then, if there's anything outside of this you want to talk about, there's the NMAPA has the Medicare Roundtable tomorrow. But any questions, comments, concerns? Oh, yeah.
Do you find that, or is it possible, if a patient only has Medicare Part A, they're beyond the 12 months to enroll for Part B, and it's been years since they were only Medicare Part A? Can you find them an affordable Advantage plan versus trying to get them into Medicare Part B?
Well, Part
Would they be
B,
eligible for it?
yeah, Part B is part of there's no way around Part B.
Well, no, like if they were to get Part B, they're going to pay penalties because they didn't take it to begin with.
Mm-hmm.
So their monthly cost for Part B may be $500 or $600
Right.
because of the penalty.
Mm-hmm.
So since they didn't enroll in Part B, are they still going to be eligible, or would they be eligible for a Medicare Advantage plan?
They've got to have Part B to get into an Advantage plan. But you know, I think most of the situations where that happens, like they could have had employer benefits, and they thought that there's this term creditable, which means it's equivalent to what Medicare offers. So they may have thought that they had credible coverage that whole time, but
Or they just simply couldn't afford the
yeah,
Part B
yeah.
treatment and no one ever helped them?
But so if you can prove that their employer didn't educate them properly about getting into Medicare on time, then there are times when Medicare can waive it. I guess if they're that poor where they can't afford the Part B premium, that's when I would screen them for Medicaid or if I don't, the Medicaid application is pretty long, but if they don't need any like additional services, you can enroll them in the Medicare savings programs, which makes them very similar to Medicaid because it pays for their Part B premium. So that's probably what I would do.
In that instance where she was talking about for the Part B, if they qualify for the state assistance like the QIMB and all that, would that not pay for the penalties also? So
Yeah.
therefore, you could enroll them in the Part B and let the state pay for the
Yeah.
penalties if they did qualify.
Yeah. Yes, that's correct. Anybody else? Yeah.
In this upcoming silver patients in Virginia, when they get a supplement, now they're moving to a different state. They said that the supplement will cover them no matter where they live as long as they took it out within the time period.
They usually will have to switch to another plan, but they, it they'll still they won't be subject to underwriting when they switch. Yeah. So. All right. Thank you all. Hey, girl.
Hey, how are you?
How are you?
Good. Good. So,
I know.
I linked you